Welcome. Today, we're going to walk through the complete neurological examination from start to finish. Think of this as a deep dive, a real masterclass designed to give you a solid, step-by-step framework that you can take right into your clinical practice. Let's jump in. So, here's our roadmap. We're going to approach this systematically, almost like we're taking a journey through the nervous system itself. We'll kick things off with some general principles that apply to the whole exam. Then we'll literally work from head to toe, covering the cranial nerves, then the upper limbs, and then the lower limbs. After that, we'll see how everything connects by looking at gait and cerebellar function before we finish up with the right way to conclude the examination. You know, before we even start thinking about tendon hammers and tuning forks, we have to set the stage. These first steps, these core frameworks we're about to cover, they are the absolute foundation for a smooth and thorough exam. Getting this part right from the get-go is just crucial. Okay, so every single clinical encounter should start with WIPER. It's a fantastic mnemonic. It stands for wash your hands, introduce yourself, confirm the patient's identity, ask for their permission, ensure you have adequate exposure of the area you need to see, and finally, reposition them so they're comfortable and ready. After that, you ask some really important opening questions, something like, do you have any pain, tingling, or weakness in your arms, hands, legs, or feet? And then, for the limb exams that are coming up, we're going to use this incredible framework called GET prices. That's general inspection, tone, power, reflexes, coordination, and sensation. This structure is going to be our guide for the rest of the exam. All right, with our framework ready, let's start our head-to-toe assessment. We're beginning right at the top with the 12 cranial nerves, and we're just going to work our way through them one by one. Cranial nerve 1, the olfactory nerve. This one's simple. You just ask the patient if they've noticed any changes in their sense of smell. Done. Now, for cranial nerve 2, the optic nerve, there's a bit more to it. First up is acuity. A good opening question is, have you had any changes to your vision recently? Then you'll test each eye individually with a Selin chart. Next, we check the visual fields using confrontation. Basically, you have the patient cover one eye, you cover your opposite eye, and then you bring a pin in from the four corners of their vision, asking them to tell you the moment they see it. You're literally comparing their field of view to your own. And finally, to map out their blind spot, you'll ask them to follow that pin and let you know when it disappears and then when it reappears. We're still on cranial nerve 2, and now we get to the really important pupillary reflexes. Step 1 is the direct response. You shine a light into one eye and watch for that same pupil to constrict. Step 2 is the consensual response. You shine the light in that eye again, but this time you're looking at the opposite pupil to see if it constricts. Then you'll do the swinging torch test, where you smoothly swing the light from one eye to the other. What you're looking for is something called a relative afferent pupillary defect, or an RAPD, where a pupil actually dilates when the light swings over to it. To wrap up the optic nerve exam, you should always verbally offer to perform a fundoscopic examination to look at the back of the eye. Okay, now we're going to test cranial nerves 3, 4, and 6 all together, because they're the team that controls eye movements. First, you just inspect the eyes. Look for any ptosis, that's a droopy eyelid, or any weird movements or positions when they're at rest. Then, give really clear instructions. Keep your head perfectly still for me and just follow my pen with your eyes. Let me know if you see double at any point. Then you'll trace a big H or a cross in the air, watching their eyes to make sure the movement is smooth. And the last piece is accommodation. You'll move your finger slowly towards their nose, and you should see their pupils constrict as it gets closer. And this diagram here shows you exactly what we're looking for. The top row is normal. You can see cranial nerve 6 pulls the eye outwards, cranial nerve 4 handles that downward and inward movement, and cranial nerve 3, the oculomotor, well, it does pretty much everything else. But the key is to see what happens when things go wrong. A CN3 palsy gives you that classic down and out look, often with a droopy eyelid. A CN4 palsy lets the eye drift upwards, and with a CN6 palsy, the eye just can't move outwards, so it gets pulled inwards. Let's move on to cranial nerve 5, the trigeminal nerve. It's got two big jobs, sensory and motor. For the sensory part, you're going to test light touch on both sides of the face across its three main branches. You've got the ophthalmic branch above the eyebrows, the maxillary branch over the cheekbones, and the mandibular branch down on the chin. Then, for the motor part, we test those powerful chewing muscles. You'll ask the patient to open their jaw and try to keep it open while you provide resistance. Then, you'll ask them to clench their jaw down hard while you feel the masseter muscles on the side to check their bulk and power. Next up is cranial nerve 7, the facial nerve. You'll start with just inspecting for any asymmetry. Is one side of the face drooping? Are there fewer wrinkles on one side? Then you'll put the patient through a little workout for their facial muscles. Ask them to raise their eyebrows way up, then screw up their eyes really tight, puff out their cheeks, show you their gums, and finally purse their lips like they're about to whistle. The facial nerve also has a couple of special sensory jobs, so you need to ask 2 specific questions. Have you noticed any changes in your sense of taste? That's for the chorda tympani branch. And are you troubled by loud noises, which can point to a problem with the tiny stapedius muscle in the ear? Okay, we can actually group the last few nerves together to be more efficient. For cranial nerve 8, the vestibulocochlear, you'll ask about any hearing problems, do a quick hearing test by whispering a number, and then use a tuning fork. For nerves 9, 10, and 12, which are all about the palate and tongue, you'll ask about any changes in their voice or with swallowing. Then have them say ah and watch to see if the palate lifts up evenly. Next, look at their tongue. You're inspecting for any wasting or fasciculations. Those are tiny little muscle twitches. Then test the tongue's power. Ask them to stick it straight out, move it from side to side, and push it against the inside of their cheek while you resist from the outside. And finally, for cranial nerve 11, the accessory nerve, you'll test the trapezius muscle by having them shrug their shoulders against you and the sternocleidomastoid by having them turn their head to each side against your hand. Fantastic. That's the cranial nerves done. Now let's move on to the upper limb examination. And remember that GETPRCES framework we talked about? Well, this is where we really put it into action, starting with G for general inspection. For general inspection, there's another great mnemonic to help us be systematic: SWIFT. This reminds us to look for scars, wasting of the muscles, any involuntary movements, fasciculations, and tremor. But beyond SWIFT, you're also just taking a step back and looking for overall symmetry, any abnormal posture, and don't forget to look at the big picture. Are there any mobility aids or medications by the bedside? These are all clues. Next in our framework is T for tone. First rule, always ask if the patient has any pain in their arm before you start moving it around. Then give them this simple instruction: just let your arm go totally floppy for me, like a wet noodle. You'll then take their arm and passively move it to feel for resistance. You'll pronate and supinate the forearm, you'll flex and extend the wrist, and you'll flex and extend the elbow. And the most important part, you have to repeat the exact same sequence on the other side so you can compare. You're feeling for any differences in stiffness or floppiness. After tone, we get to P for power. Now, to do this properly and objectively, we use the Medical Research Council scale, or MRC scale. It's a standard scale from 0 to 5. So 5 out of 5 is completely normal power. 4 is movement against some resistance, but it's not full strength. 3 means they can move against gravity, but not against any of your resistance. 2 is movement only if you take gravity out of the equation. 1 is just a tiny flicker of a muscle contraction, but no real movement. And 0, well, that's complete paralysis. Using this scale is absolutely essential for good documentation. So what movements do we actually test? We work our way down the arm, from the shoulder to the fingers. And as you can see here, each movement corresponds to specific nerve roots. We'll test shoulder abduction, which is mostly C5 and C6, and also adduction. Then we'll move to elbow flexion, C5 and 6, and elbow extension, C7 and C8. Down at the wrist, we'll test both flexion and extension. And finally, in the hand, we'll check finger flexion, extension, abduction, and adduction. For every single one of these, you'll be asking the patient to match my strength and resist your movement. The R in GETPRICS stands for reflexes. And just like with power, we have a grading scale to keep things standard. 0 means a reflex is totally absent. A single plus, or plus, means it's present but definitely reduced. Double plus is what we consider normal. Triple plus means it's increased or brisk. This can sometimes be normal for people, but it can also be a red flag. And 4 plus means it's really, really increased, and often comes with clonus, which is that rhythmic beating contraction of the muscle. In the upper limb, there are 3 main reflexes we need to test: the biceps reflex, which checks C5 and C6, the triceps reflex for C7 and C8, and the brachioradialis reflex, also C5 and 6. Now, if a reflex seems a bit weak or absent, you can use a trick called reinforcement. Just as you strike the tendon, ask the patient to clench their teeth hard. That brings us to C for coordination. We have 3 main tests here. First is the finger-nose test. The patient touches their own nose, then your finger back and forth. Second, we test for something called dysdiadochokinesis. It's a mouthful, I know, by having them rapidly tap the back and front of their hand on their other hand. And third, we check for rebound by pushing down on their outstretched arms and then suddenly letting go. The last part of our upper limb exam is S for sensation. And to do this right, we need to test specific spots on the skin that are each supplied by a single spinal nerve root. We call these areas dermatomes. This map shows you the key spots to test. C4 is right on the tip of the shoulder, C5 is on the deltoid, that kind of regimental badge area, C6 is the thumb, C7 is the middle finger, C8 is the little finger, and T1 is on the inner part of the forearm. Now we have to test different types of sensation because they travel along different pathways in the spinal cord. For light touch, which travels in the posterior columns, you'll use a little wisp of cotton wool. And make sure you just touch the skin, don't stroke it. For pain, which travels in the spinal lambic tract, you'll use a disposable neuron tip. You should first demonstrate what sharp feels like on their sternum so they know what to expect, then test the dermatomes, asking if it's sharp or dull. For vibration sense, another posterior column modality, you use a 128 Hz tuning fork on the very last joint of the middle finger and ask them to tell you when the buzzing stops. And finally, for proprioception or joint position sense, you'll hold that same joint, show them this is up and this is down, and then have them close their eyes and tell you which way you're moving it. So on top of thinking about dermatomes and nerve roots, you also have to think about the big peripheral nerves in the arm. The radial nerve is the boss of the extensors. A classic sign of a problem is wrist drop, and it gives sensation over the anatomical snuff box. The median nerve supplies most of the flexors in the forearm and the important loaf muscles of the hand. This is the nerve that gets squeezed in carpal tunnel syndrome. And finally, the ulnar nerve takes care of most of the small, intricate muscles in the hand. A lesion here can cause a claw-hand deformity and what's called a positive Froment's sign. All right, let's head down to the lower limb. And guess what? We're going to follow that same familiar sequence: inspection, tone, power, reflexes, and sensation. The principles are exactly the same, but the specific tests are, of course, tailored for the legs. For inspection, you need the legs fully exposed. You're looking for all the same things: symmetry, muscle wasting, any fasciculations, scars, or abnormal posture. To check tone, again, always ask about pain first. You can assess tone at the hip by gently rolling the entire leg from side to side. To check the knee, you lift the leg from behind the knee and feel for any unusual stiffness or floppiness as it bends. And a really key test in the lower limb is checking for clonus. You do this by sharply and briskly pushing the foot up into dorsiflexion. And as always, compare one side directly to the other. Now for power testing in the leg, we again work our way from the hip down to the toe. We test hip flexion, which is mainly L2 and L3, and hip extension. We also test hip abduction and adduction. Moving to the knee, we test flexion, L5 and S1, and extension, L3 and L4. At the ankle, we'll check both dorsiflexion and plantar flexion. And finally, a really important and specific movement is asking the patient to extend their big toe. This is a great way to isolate and test the L5 nerve root. Okay, reflexes. The three big ones here are the knee jerk for L3 and L4, the ankle jerk for S1 and S2, and the plantar reflex. Now, the plantar reflex is absolutely critical. You test it by stroking the sole of the foot. Normally, the toes should curl downwards. An abnormal response, which we call a Babinski sign, is when the big toe goes up and the other toes fan out. That is a huge sign of an upper motor neuron lesion. For reinforcement down here, we use gymnastics maneuver, ask the patient to hook their fingers together and pull them apart. And for coordination, the main test is the heel shin test, where they have to run the heel of one foot smoothly down the shin of the other. And we finish the lower limb exam with sensation, once again testing those key dermatomes. L2 is on the medial or inner mid-thigh. L3 is on the medial aspect of the knee. L4 is over the medial malleolus, that's the bony part on the inside of your ankle. L5 is tested in that first web space on the top of the foot, right between the big toe and the second toe. And S1 is tested on the lateral or outer side of the heel. All right, now we're at a part of the exam that really pulls everything together: assessing gait and cerebellar function. A lot of the things we test here, we've actually already touched on during the limb exams, but now we get to see them all working together in complex, coordinated movement. We assess gait in a clear sequence. First, just ask the patient to walk normally across the room, turn around, and walk back. You're just observing their posture, their stride, everything. Next, to make it a bit harder, you'll ask them to walk heel to toe, like they're on a tightrope. Then, ask them to walk on their toes. This is a great functional test for S1 power. After that, have them walk on their heels, which really tests L4 and L5. And finally, to look for any proximal muscle weakness or myopathy, ask the patient to do a full squat and then stand back up without using their hands for support. Romberg's test is a very specific test for balance, and the interpretation is everything. Here's how you do it. You have the patient stand with their feet right together, first with their eyes open. Then you ask them to close their eyes. Now, if the patient is already wobbly and unsteady with their eyes open, that points you towards a problem with the cerebellum or the vestibular system. But if they are perfectly steady with their eyes open and only become much more unsteady when they close their eyes, that tells you something different. It suggests a problem with proprioception, a sensory ataxia. They're using their vision to compensate for the loss of position sense, and when you take that vision away, the deficit is unmasked. To bring together the full cerebellar exam and make sure you don't miss anything, you can use the mnemonic PINARDS. And look, we've already done most of these. P is for pass pointing, which we saw in the finger-nose test. I is for intention tremor, that tremor that gets worse as they get closer to a target. N is for nystagmus, the eye flicker we looked for. A is for ataxia, which is the unsteady gait we just assessed. R is for rebound. D is for dysdiadochokinesis, those rapid alternating movements. And finally, S is for staccato or scanning speech, a kind of jerky speech pattern that you would have been listening for throughout the entire examination. So, we've now finished all the physical parts of the exam. But we're not quite done. The last part is just as important: how to wrap up the encounter professionally and how to summarize what you found. These final steps are simple, but they are non-negotiable for showing respect and maintaining good practice. First, you always thank the patient for their time and their cooperation. Second, you make sure they have privacy to get dressed again. And third, you always wash your hands after you've completed the examination. After you leave the room, you need to be able to summarize your findings clearly and concisely. If everything was normal, a simple professional statement is all you need. Something like, "This was a normal lower limb exam with no evidence of motor or sensory deficit." That's the kind of summary you'd use for your notes or when presenting the patient. And to finish up, I want to leave you with a question to really get you thinking. We've spent this whole time breaking the exam down into these neat little sections: cranial nerves, upper limbs, lower limbs. But of course, the nervous system is one big interconnected network. So how might a single focused problem, like a stroke on one side of the brain, show up across all three parts of this exam? Thinking about how these different findings link together, well, that's the real art of clinical neurology.